Dr. Robert Wall, which is the president-elect of the American Medical Association, first one of Chinese origin, and one of the youngest one holding that role. So please, Robert.
Good morning, everyone. It's a great privilege to be here with you. I was just telling people on the bus, in Washington, D.C., which is quite a bit farther south from here, we just had snow on Monday. And so we had 15 centimeters of snow, which is nothing compared to what you have out here. And the entire city was paralyzed for 24 hours. We don't handle it the way you do out here, so it's a great difference to be up here. Sorry. So I'm a practicing reproductive endocrinologist, infertility specialist. I do microsurgery and endoscopy at the National Institutes of Health and the Walter Reed National Medical Center in Washington. But I also am quite involved in health information technology as the chief medical officer of a company called CSC, Computer Sciences Corporation. So my background is both in obstetrics and gynecology, reproductive endocrinology, as well as health information technology through my work in the U.S. military and the U.S. government. I had the opportunity to be the Associate Chief Information Officer for the military health system, taking care of about 10 million people worldwide. And then I moved over to the U.S. Health and Human Services, where I helped start up the Office of the National Coordinator on Health Information Technology. And we developed a national strategy for health IT in the United States. So that's a little bit of the background where this all comes from. What we thought, in talking with John, we thought would be useful is we're talking about the collection of health information in the databases and biobanks. I'm not going to speak so much about that as why do we want to do it? What's the value? What's the reason why we want to put this information together? What's the opportunity that we have in using health information technology? So one of the things that I've spoken about a number of times is it's my belief that health information technology in healthcare is the technology actually delivers better information for better decisions. And so all of us in healthcare, whether we're patients, doctors, governments, payers of healthcare, or researchers, we will all use better information to make better decisions. And the technology gets us that information at the right place, the right time, in front of the right person. And so that's what I really think the technology is for. It doesn't teach us how to do better surgery, it doesn't teach us about how to make better diagnoses, but it does put the right information in front of us at the right time to make a better decision about how we treat our patients. I thought I'd tell you a little bit about where we are in the United States in moving forward with health information technology. So I started the Office of the National Coordinator in 2005, 2006. And back then, President Bush was the president, and the prevailing government philosophy then was everything should be done by the marketplace, not the government. And so we had a very, very, very small budget. And then in 2009, when President Obama was in office and we were having a significant financial recession, the decision was made to make a large investment in health information technology in the United States. And what they wanted to do was make an investment that would put a technology foundation in place on which they could build health reform. The feeling was we could not reform our healthcare system so long as it stayed on paper. And so we invested billions of dollars to move everybody off of paper onto a digital platform. And so I made this slide back in 2009, kind of looking at how the money would be spent. And so there's 3 waves of spending, or 3 waves of activity that I saw. First, we were going to give doctors and hospitals financial incentives to move off of paper onto a digital platform. That's that large blue curve there about EHRs, or electronic health records. And so the US government committed something in the neighborhood of $30 billion to get people off of paper onto a digital platform. And then this smaller one, HIE, stands for Health Information Exchange, which is where we network the information together in a digital way. And so they spent about $1 billion to make that connectivity. And back in 2009, when I made this slide, I projected that red line right there, which is once we have everybody off of paper onto a digital platform and it's connected digitally, we're going to want to do some powerful things with it, which is that red line, which is we start looking at populations similar to the genetic information that they've done here, but in much higher detail. Now we can look at, instead of individual patients, we can look at all the diabetics or all the people with hypertension and see if there are trends or there are ways we can impact or improve the healthcare of those populations. We'll also want to do some very specific analytics that we were never able to do when it was on paper. And so I think we're right now starting to see the takeoff of that red line, which is the intersection of what we're talking about here today and what the World Medical Association work group is talking about. Because that's where we're going to start accessing the databases that are created when we get off of paper onto a digital platform. So I just thought it'd be useful to see where we are in the United States right now. I think it's similar to where many other countries are as well, but I just thought I'd show where we are with this. So when I've talked about this, I've talked about this intersection that's occurring between health information technology, cloud computing, and cybersecurity. Now, if you follow technology at all, those are some of the biggest hype words in the industry today, cloud computing and cyber and health information technology. But I really believe that in the center of this intersection is our patients. And so I really believe that we need, as people who are in healthcare, this is what we look at in terms of that. So I want to speak a little bit about each one of those segments. I've talked a little bit about health information technology, but cloud computing, there's a lot of different dimensions to cloud computing. Amazon, they're the big sort of new thing in cloud computing, where you can just take your credit card and go online and buy computing power. It used to be if you wanted to do a million calculations in a minute, you had to build a data center, put in racks of computing processors, get memory and all that kind of stuff. It was very expensive. Now you can just take your credit card, go online and say, I want to buy 2 million transactions in the next 30 days. Here's my credit card. And it's like buy the drink. You just order it and you get it. And so that's part of what cloud computing is. The other part of cloud computing is that we're now able to separate where the computing happens and where we see the results of the computing. And so that opens up a whole number of possibilities where we have all these devices, and I think all of us now carry a laptop, a tablet, a handheld. Think of those instead of instruments of computing, think of them as viewers into the computing. So what I have depicted here is all of these devices going from your desktop machine at the office or home down to your handheld and everything in between. Borrowing, at Aunt Edna's, if you're traveling on vacation and you happen to be at a relative's house, all of those devices can be a window into some computing that can be, miles or thousands of miles away. And so what that does is it opens up a huge opportunity for us to have access to very powerful sources of information without having to be right next to where it's created. Okay? And so I believe that this is one of the things in healthcare that's going to really change the way we take care of our patients. Our patients are expecting to have access to this information. We as clinicians, we believe that we can do a much better job of taking care of our patients if we have ready access to a lot of information that this can offer. So I'm very excited about the possibilities that are coming with cloud computing. In addition to being able to just use my credit card to get computing power, the fact that I can see the results of computing anywhere I am using these little viewers. I also believe that it's important that we talk about cybersecurity in healthcare. It's my belief that we are underprotecting ourselves in this area because we just aren't paying enough attention to it. This is a chart that we made a couple of years ago. Each one of those little red dots represents a data breach in a healthcare organization somewhere in the United States. And you know, in the financial services, we're hearing a lot about this right now. You know, the news in the United States over the holidays was one of our large retail chains, a company called Target. Unfortunately, it's their name. They were also the target of cyber criminals who wanted to steal credit card information from people. And interestingly, the cyber criminals broke into the Target system in a very unusual way. They hacked through their thermostat, the thing that controls the temperature in the stores. You know, it's computerized now because they have 1,000 stores across the United States, and one of their biggest bills is the heating and cooling. And so somebody sold them this system where they can control the temperature in their stores via computer and cloud computing. And so somebody figured out a way to hack into that thermostat system, and that got them into their entire network. And so they were able to use that little vulnerability. You know, who would think, you know, who wants to get into my thermostat, right? I mean, it's not particularly interesting. You know, so you make my room a little cold. It's no big deal. But what they didn't think about was, because it was connected to their greater network, that little portal, that little vulnerability, Achilles heel, if you will, allowed the cyber criminals to get in their entire network, and they stole 140 million credit card information from the store. And so that became a huge news story. It's still going on. They're still talking about all those breaches. But what we're not thinking enough about in healthcare is we have the same, if not more, vulnerability than the financial institutions in these stores. And there's two things about that. One is our patients are very concerned about this. When they think about electronic records, one of the first things our patients are concerned about is my health information going to show up on the internet? Because they've seen it. They've seen credit card information showing up on the internet, banking information. You know, in the United States with the NSA, you know, we're seeing our phone calls show up on the internet. So all of that is very much in the minds of our patients. And one of the things that we as healthcare workers, you know, we've always been entrusted with confidential, private information from our patients. And we have been the data stewards from the beginning of time as physicians of very confidential information. We have to maintain that data stewardship as we move into the digital age. And so one of the things that I always talk about, one of the reasons why patients are concerned about this, is that if their credit card information shows up on the internet, it's a big problem, right? You know, it takes you years to unravel all the problems if somebody steals your credit card. But it's fixable. If your health information shows up on the internet, if the diagnosis that you may have that's embarrassing or very damaging, like if your diagnosis of HIV shows up on the internet, or that if your boss finds out you're a diabetic, or your family members, you know, John was talking about how, you know, when they did the genealogy of the citizenry here, it showed some embarrassing things that people didn't expect it to show. Well, you know, if your sexual transmission of disease, the sexually transmitted diseases show up on the internet, or the fact you're on psychiatric medications, or something like that, shows up on the internet, that's different than if your credit card shows up. Because the credit card you can fix. You cannot change the fact that everybody knows now your diagnosis of psychiatric disease or sexually transmitted diseases. We talk about how that's a bell you cannot unring. Once the bell rings, you can't unring it. So patients are very aware of that, and I think we as physicians need to be very mindful of our role as data stewards of the information. But the other part of it is it's no longer just the curiosity seeker that are looking to display that health information. You know, when we first started having digital records, one of the biggest concerns was a celebrity comes into the hospital and the front desk clerk wants to dig around in the records and find out something juicy that the press would want about that celebrity. You know, so people like Madonna or, you know, I don't know, name a celebrity. If they checked into the hospital, they were also at risk that their health information would be disclosed. And in the US anyway, the media, you know, they pay these bounties, literally a little prize if you can steal some sort of secret out of the medical record so they can publish it and make headlines. So there were thousands of dollars of these little bounties. So that was our initial problem. But now, cyber criminals are actually targeting health information records because they found that they're such a rich source of information about a person that they can create a whole nother identity just using a health record. And so our security people that I work with tell us that the street value, you know, they call that what the criminals pay each other for this information. A credit card is worth $1. A health record is worth $15 to $20. So there's a $15 to $20 fold multiple of health information as opposed to credit card information. And the reason is because you can turn a credit card off. If you lose your credit card, you call a toll-free number, the bank turns it off, right? You can't turn your health record off. Once that gets out there, they can start making another identity, and using that identity, they can borrow money, purchase cars, purchase houses, they can do all kinds of very substantial things with that. And so the street value is much higher of a health record. And so that means the criminals, so they go where the money is. If it's 15 to 20 times more valuable than a credit card, they're going to start targeting their efforts at health information repositories, whether that's in a hospital, a doctor's office, a nation, whatever. And the bigger the better, right? So, if you can steal 1 million health records from some source, it's going to be targeted just like the financial records are in the country as well. So I think we all have to start thinking a lot more about security. And it's not just for the casual front desk clerk that wants to find Madonna's blood type or the last time she had surgery. This is about cyber criminals targeting health information for very nefarious, significant criminal activity. This is one of the things that we are talking a lot about in the United States. My company, CSC, we're working a lot on this as well. And so we're working with large institutions about how they protect their information. But at the same time, it's important that we think about security a little bit differently than what we currently do. Right now, everybody sees security as a little bit of a bother. It's a hassle, it's an obligation, it's a cost. And we need to think about it differently. We need to think about security as an enabler, because we won't be able to have these databases, these collections of information, this digitally networked system of information. Patients will stop giving us the information if they don't believe we're able to take care of it. So we need to think of security as an enabler that gets us to where we want to be, and where we want to be is to have this networked information together that allows us to do these very powerful things, helping take better care of our patients with better information for better decisions. I want to switch gears real quick because I know in our work group we're going to talk a little bit about biobanks and why some of this is really taking off as well. This is an interesting slide that was put out by the National Institutes of Health. There's a thing in the United States started by Intel, the corporation that makes a little chips and a lot of computers. They have this thing called Moore's Law. An engineer a number of years ago, way in the 60s in fact, predicted that computing power was going to double roughly every 2 years. And so that was called Moore's Law. It was really about how many transistors can you fit on a little chip. And he believed that every 2 years we're going to double the number of transistors we could fit on a chip. And interestingly, that prediction has played out very, very true for 20 plus years. So that white line that you see there is called Moore's Law, where we're doubling the computing power every 2 years. The blue line is how much it costs to do the analysis of genetic material. And so initially, as Moore's Law was going, so was the price falling of how much it costs to do genetic analysis. And so it pretty much paralleled it until you saw that big drop off there. I mean, the cost just went dramatically downward to the point where now, as you see here, it's down to the point where to do these analyses has gotten very fast and very inexpensive. And so by having that ability to do very, very complicated calculations and analysis on genetic material, and the cost has gone down so much, it's opening up a whole new realm of possibilities about what we can do with genetic information. But I just wanted to show this because it's quite dramatic in terms of how amazing that drop is. So that's led to a lot of activity in the United States. And I showed just some websites of things that people are thinking about doing now that we have the opportunity to have access to this kind of information. Up in the upper right there is a project by the Veterans Administration of the United States. The Veterans Administration for the United States is all those people who ever served in the military. Anybody who's ever served in the military is considered a veteran. And so there's about 16 million or so veterans in the United States today that are still living. And so they've started a project called the Million Veteran Project, where they're asking to get blood samples from 1 million veterans. And they're going to take that information and do genetic analysis on it and build a library of 1 million veterans and see if there are trends or commonalities or anything in that. They don't really have an idea about what they're going to find. They just want to, they believe though that there's a huge potential to gain a lot of information if we have the blood sample of 1 million veterans. You know, there's this 1,000 Genome Project, there's a group, Foundation One. Many people believe that the first area that's going to be very helpful for genetic analysis is in the area of cancer. We've all seen that historically we've taken care of cancers by the tissue that it comes from. Lung cancer, ovarian cancer, you know, all these cancers, we all think about them as the source of the tissue that they come from. But what we're finding out is that there's a lot of variation amongst the tumors themselves, which leads to us believing that we're mistreating, you know, some people say as high as 60% of the cancer treatments that are out there are not effective against the cancer we're treating. And that's because we assume all cervical cancers that are of squamous cell type all respond to a certain chemotherapy. But we all know as physicians that some respond and some don't. So we're trying to figure out if we understood the genetic makeup of the tumor itself, maybe we can more specifically target our therapies to be much more effective against that particular tumor, as opposed to all cervical cancers being treated the same way. So a lot of work is being done in that area. Here's another set of examples. Partners is the Harvard Medical School teaching hospitals, Mass General, and the Brigham getting together. They're now offering a service about genetic information. Illumina is another one that can do whole genome sequencing services. They're saying that we can sequence the entire genome for $1,000. That's an incredible number. It was millions of dollars just not that long ago. And now we're down to $1,000. We can sequence the entire human genome. And then I wanted to talk a little bit about what sort of the consumer, you know, we go back and forth about are they patients or are they consumers, but we're talking about the general public now. They're getting involved in this as well. And one of the things that really drove that was this group called 23andMe, where you take a swab of your mouth, send it in on a little stick. For $99, they'll do an extremely detailed genetic analysis. It's not the entire genome, but they'll give you a lot of information about your genetic makeup and how that compares to your ancestors. And actually what happened was they were making some predictions about your health based on the genetic analysis that they were finding. And the Federal Drug Administration intervened and said, you know, you're really getting into making some medical advice now, and you're not really qualified to do that. And so they went back and forth. So you see a little disclaimer, that little blue bar up there. You can't read it, but it now says, this is not medical advice. You know, it's like the fine print on the ad. You know, so they now have to disclose, we are not giving genetic or medical advice. We're just telling you about your ancestors. So that's what they are. But $99, I mean, the general public is thinking, wow, you know, I can get a lot of information for $99. And then there's these other ones that can talk about tumors. And then there's this new website called Patients Like Me. This is where the brother of a person who had a very debilitating neurological disease, amyotrophic lateral sclerosis, which is about 100, it's essentially 100% fatal, but it's very progressive. And he was very frustrated because his brother had this disease and he couldn't find any good information about it. And so he started a website. He's an MIT engineer. He started a website that says Patients Like Me. And he pretty much said, anybody else out there got this really debilitating, unusual disease that you want to share information about it. And to his amazement, people just flooded this thing. And so people would put very personal information on this website in the hopes that it would help them or people like them very quickly. And so we all think about patient privacy and how our patients are worried about their privacy. But I'll tell you that when you have a lethal, fatal disease, those patients will tell you the last thing I'm worried about is my privacy. What I'm worried about is dying, you know? So they on this website, they put down the most personal information you can imagine on this website. And they do it in the hopes that by sharing that information with the larger community, someone will come up with something that will help them, right? So they're putting their blood tests on there, a long narrative about, I went to see Dr. Waugh today, this is what he prescribed for me, this is what we talked about, this is how big, you know, the tumor is. I mean, all these they put x-rays up there, very, very personal information. And they're completely turning this whole privacy idea on its side, because, like I said, it's a different mindset. When you have a lethal disease, you know, do you really care about your privacy? And the people that started this, you know, the sort of initiator, he's going around the country saying, you know, privacy is killing patients. Because we're holding on to the information too tightly, it's not allowing us to have a very open discussion about what works and what doesn't work, and share information and move things along very quickly. And so he's got a whole different view of privacy than many of our healthy patients. The healthy patients are very concerned about, you know, I don't want my psychiatric meds on the website, I don't want my sexually transmitted disease history. But you know, when you have a lethal disease, it's totally different. So I just present that as something, another dimension for us to think about as we discuss privacy, security, and the health databases that we're creating. I'll leave these slides, and I don't want to go through this, but at the American Medical Association, as you all know, we create policy in a large body of 525 physicians from around the country that establish a policy for the organization. And we have a fair number of pieces of policy on genetic analysis and genetic collections of information. One of the things we're very concerned about is the idea that you would be genetically identified and then discriminated against just purely because of your genetic makeup. Because as we all know as physicians, your genetic makeup says you're at risk for things, but it doesn't guarantee you're going to get them. So if you're at risk for something, should you already be assumed to have it and treated differently? Whether that's, you know, the cost of your insurance or, you know, your ability to get a job, all that kind of stuff. So we're very concerned that we don't want our patients to be discriminated against just on the basis of their genetic makeup. And then we have a number of other things about how are we going to face this really large explosion of information that's coming out of the fact that we can do a complete genetic analysis for $1,000. And so that's some of the policies I'm sharing with you here. And then I just want to end up by saying my view, going back to my better information for better decisions, is that we're rapidly moving towards what I have here. In the center is this grand healthcare platform. It's not like a big database in the sky, not one single machine. But imagine a virtual pool of information about our patients. And everybody around the circle here, patients, physicians and nurses, hospitals, payers, labs, researchers, governments, everybody's going to contribute to that pool and pull information out of that pool, right? And because once it becomes more liquid, once the information becomes more free-flowing, that will allow us to do things that we never were able to do on paper. Now, how we get in and out of that pool are those little yellow arrows, and that represents the technology that's going to allow us to get in and out of that pool, but also represents the policies about privacy, security, all the things we're going to be talking about in the work group, because that's going to be embodied in those yellow arrows. Because I think we need to think just as much about the getting out and getting into that pool as we think about the pool itself. So I thought it'd be useful for us to think about what's the opportunity that we have in front of us by having digital information together, as we also talk about the privacy and security of how we maintain those databases. Because I think they go hand in hand. You can't have one without the other. Because if we don't have privacy security and some policies and governance about how we're going to handle that information, we at some point will not be able to have that virtual pool and that liquid nature of the information free-flowing to help us take better care of our patients. So I hope that's useful for you. I'd be happy to answer any questions if there's time. But we thought that'd be a good way to start the morning. So thank you very much. Yeah, so that's one of the big controversies, right? So, the United States is a very diverse country. Everybody believes we're independent, and so we're fiercely adhere to that principle. It's my belief that right now the society is not ready to go to an individual identifier. There's a certain concern that if everybody had a number associated with their healthcare, that the government would be able to watch you more closely. I think with the NSA revelations, that's probably a little bit antiquated way of thinking, right? Because, you know, if you think about it, the government's already watching us quite a bit already. So, but I would just tell you that there's a strong reluctance on the part of the society in the United States to go to an individual identifier for every citizen. Interestingly, the UK, I guess our UK representative didn't make it, you know, they started the National Health Service in the UK over 60 years ago. And at that point, every citizen got a number for the National Health Service. And, you know, they're a pretty significant part of society in the world environment, and nothing happened. And, you know, the world didn't go bad because everybody got an ID number. But there is a reluctance in the United States to have a number. And then there are people in the technology world that say, you really don't need to have a unique identifier for every person. In fact, we believe that using new technologies, we can identify every person in the United States on 5 pieces of demographic information. So your name, your phone number, your age, and your zip code, your postal code. You can almost just take 5 pieces of information and uniquely identify every patient. And so maybe we don't need to assign a unique number. But that's an ongoing discussion that we have in the United States.
We have a second question from Otmar.
Yeah, I just want to confirm, I think the identification is not that much a problem, and you can, with very simple things, identify patients very closely and narrow that down very easily. Even from a very remote perspective into another healthcare facility, it's very easy to do that. But that brings me also to the second question, and that those are the revelations we have heard about NSA. What we see now in the countries, especially in Europe, which has been very much affected by the work of the NSA, that people are distrusting any security measures. I fear that many people are now saying, no, I'm not going to sign up to any network use of my data because of that. Is that something you are addressing in the United States? Because it will cost probably a lot of lives.
Yeah. Yeah. I mean, I think that's why I think this work group is important to discuss. Like I said, I think if the general population doesn't have some confidence that people are being good stewards of the information that they give them, they'll stop giving it. You know, and that will throw sand into the gears. Like I said, we are going to, you know, all the promise of what I sort of put up there is very dependent on what I call some data liquidity, the ability for information to flow like water. And if it flows like sand, you know, it's not going to be good. It's going to be a problem for us. So that is a huge issue that I think we all have to be mindful of. So I think that's very much in line with what we're talking about at the work group here.
Thank you. Thank
All
you
right.
very much, Robert.
Thank you very much.